There is some echo at your end, Dr. Amit.
Yeah. That's okay.
Yeah, there is some problem.
No problem. Take care. It's okay now?
Yes, it's okay.
No, it's okay.
So that if we run into problems, you can help us.
Hello, yes. You want to share your slides? No, it started. Yours is 8 o'clock, but you can tune in now. Yeah, but a sharp 8 o'clock, huh? Hello, good evening, everybody. Good evening to the inaugural session of the Onco section meeting of the USI. This is a new section, and we have ambitious plans about special units of the UCCon, of which this is one of the most popular. We are going to host, we have the privilege of having 2-star guests today, Professor Mahendra Bhandari and Professor Prokar Dasgupta. To begin with, can I first of all ask Dr. Ravindra Sabnis for his opening remarks this evening.
Thank you, Dr. Amit. Thank you very much. Well, on behalf of Urological Society of India, it's my great pleasure to invite and welcome all of you for this, as Dr. Amit said, the inaugural Uro-Oncology section of USI meeting. Well, we had a lot of plans about looking at the situation. We thought that this would be ideal to have the first inaugural meeting in the form of a webinar, and that's how we are all meeting today. I must congratulate Dr. Amit Ghosh for taking the lead, and all the conveners of the Uro-Oncology section of USI, Dr. Ganesh Bakshi, Dr. Ravi Mohan, and Dr. Santosh Kumar, for nicely coordinating this particular webinar and putting a great program. Well, on behalf of USI, it's my great pleasure to welcome Dr. Prokar Dasgupta and Dr. Mahendra Bhandari. Both of them do not need any introduction. Prokar Dasgupta has been associated with USI for a very, very long time. He's been coming to our UCCons. He's training and mentoring a lot of people from India. And I think USI is really privileged to have Prokar Dasgupta as a strong pillar, who is a supporter of USI. And he is one of those few people who actually have gone outside and acquired a huge name outside and kept on Indian flag flying very, very high. So thank you very much, sir, for taking your time and coming for this program, which is on a completely different aspect altogether. And I've heard your lectures in the past about the AI and your work, which you have done on AI, and we are very, very eager to listen to you on that particular subject. Well, Dr. Mahendra Bhandari, of course, he has nurtured USI. In fact, many of us are his followers, his students, and all of us, actually our batch and our generation is very much obliged to Dr. Mahendra Bhandari. He has put in a huge amount of efforts to take the USI to the height and the fruits of we are testing. They have done the struggle, but we are actually testing the fruits, what the struggle and what hard work they have put in at that time. So, sir, we are privileged to welcome you. And you also have done lots of research and lots of work on this particular subject of AI in uro-oncology. And we certainly will be very, very eager to listen from you on this particular new topic. So with this introduction, I also wish to welcome all the delegates who have joined from different places. I'm sure there is a lot of enthusiasm moment the circular of this particular program was circulated. People got a lot of interest in what exactly is happening in AI front and how it is going to affect us, whether it is good, whether it is bad. And they kept on sending the message and calling me that what is this topic? I said, the suspense will be over. You just have to log in and join. So there are many people who will be joining and listening to these two stalwarts. And of course, Zishan is our own student, a young dynamic urologist, upcoming budding urologist, who also gave his insight as to what this particular thing is. So with this short introduction and welcoming all the delegates, I again hand over mic to Dr. Amit Ghosh to carry out the further proceedings. Thank you very much.
Thank you, Dr. Sabnis. It has been a pleasure for the last few months to have been working on this innovative idea, which is going to actually see USI in very good light. I mean, the different subsections was a necessity. And the way USI is growing, it will give us scope to a lot of urologists to take the lead. And I have personal experiences of nurturing the uro-oncology section in its infancy with tremendous help from the other three of us. It is not only me. I'm not taking any credit out of it. It is Ganesh Bakshi, Ravi Mohan, and Santosh from Vellore, who's unfortunately flying at this point of time and therefore cannot join us. But tremendous efforts. We've had very good response. In fact, when the membership was called for, we were one of the top two sections which the urology members actually showed interest in. Let us come to today's format. Today's format is that with the vast experiences of the guests that we have, I thought myself with my colleagues that it will be nice to have Professor Prakhar Dasgupta in a conversation with Professor Anup regarding the long journey of prostate cancer as it was and as it is, and what is the future. I don't think we will go into the exercise of introducing Professor Prakhar Dasgupta, except for the fact that he is the new kid on the block with the Padma Shri that he has won for his contribution to Indian science and contribution to science in general. Just to remind everybody, he has been one of the star Bengalis, if I may first say. He's first a Bengali, then an Indian, or the reverse way around if you think so. But he was the first colored man to have become the chief editor of one of the significant journals of urology, which he has captained for 10 full years. Even before that, he became the chairman of robotic surgery at Guy's Hospital at a very, very young age. I shall not go into his expertise. Then I think the whole of the evening will be dedicated to him. With apologies for not going through his entire CV today, let me introduce Professor Anup Kumar, who is the professor and chairman in the Department of Urology and Robotics and Renal Transplantation in VMMC, New Delhi in India. He's the program director of AUA Endourology Clinical Fellowship in Advanced Robotics, and of 2 years duration, he's the convener of the first USI Cancer Prostate Guidelines. And in one word, he is one of the leading lights in the youngish brigade of urology leading India into the future. So Professor Anup is going to be in a conversation with Professor Dasgupta while I will be sandwiched between the two to go on convening in as and when necessary. The important thing is, it will be a conversation. There will be no presentation for the time being on different vexed questions of prostate cancer. It will be interesting to know both their opinions, both the person who's questioning and the person who's supposed to answer. It is a conversation and we will enjoy the fruits of it. May I now hand over to Anup to start the session and welcome Professor Dasgupta into the conversation.
Thank you very much, Dr. Ghosh, sir, for this very kind words. And it's really my privilege and honor to have a conversation with one of our idols, Dr. Prostate Dasgupta. And I also have indirect relation with him because I'm a fellow of Dr. Patel, who is a very good friend of his. So he used to tell about Dr. Prostate Dasgupta during our fellowship a lot. So now I want to start the conversation, and Professor Prostate Dasgupta, welcome to USI and welcome to India once again. So my first question is that for the last few decades, what do you think that if we talk about the change in the prostate cancer disease stage, do you think what's the major change you have seen over the last few decades? We'll talk about European countries, and then we'll talk about Indian countries, India and the other developing countries. So you can talk about your European countries, what change you have seen in the stage and the grade of disease in the last few decades.
Before Prabhu answers, can I just beg apology for my interferences, if any, which will be only for the time keeping, because we want to hear lots of it, but little of it for each question. And therefore, I'm going to stop anybody who overdoes. And pardon me for that.
So thank you, Anup. I hope Vipul kept saying good things about me. You never know. But look, the words are stage migration, and to that I would add for the better. When you and I were training, you in the United States and myself at the Institute of Urology in London, certainly in UK, the majority of patients who presented were with metastatic disease, with a 20% 5-year survival rate. And I think over the last 20 years, that has certainly changed. Within the UK, we are picking up disease more early, thanks to PSA, MRI, and more awareness, which just wasn't there when we were training. And I think that gives us an opportunity to cure many patients who were previously deemed incurable. So diagnosis and awareness are the two things that have changed. But in parallel, I think the treatment has also gotten better. We know not to overdiagnose and not to overtreat. We have better operations. We have more focal treatments. We have better radiation. And even in patients who have advanced disease or metastatic disease, we have new hope, which I hope we will be speaking about in the next half an hour. So I think stage migration for the better.
Yeah, and Dr. Prokar, do you think the PSA screening, that's again a controversial topic in many countries. USPSTF have recommended against PSA screening or patients more than 7. It can be a shared decision making. What do you think? Is it really the PSA screening which is helping us for the stage migration along with the testings?
I mean, as you know, in the United States, they were certainly screening men from 50 onwards with a digital rectal examination and a PSA, but that recommendation changed and they have started seeing disease at more advanced stages, just like we did in the UK. But neither the National Institute of Clinical Excellence in the UK nor the EAU recommends screening. But this is, as you say, shared decision-making, or what I call smart screening, whereby if a patient with a family history or even at the age of 50 without any symptoms approaches their general practitioner or urologist for a PSA test, we counsel them. If they have symptoms, we certainly counsel them. And I don't think these men should be denied a PSA test if that's what they are asking for, as long as they understand what that counseling involves and what it may lead to. So just saying, okay, here is a blood form, and the nurse in a GP surgery just sticking the PSA without telling the patient that it is being ticked is not the right way to go. At the same time, a well-counseled patient has the right to demand a PSA test.
Can I just butt in for one moment? Hello?
Yes.
I just wanted to ask Prokor, if in an informal party, a friend, 55-year-old,
Yes.
asks you, should I get a PSA done? What would be your answer? This is a common social problem in India. I don't know where elsewhere also. What should be, beyond, with science in the background, what would be your social answer?
My social answer would be, as long as they understand that it is an imperfect test, that a single PSA is not very helpful, and that they need to have a continuum of PSA and how it is behaving over a period of time, then there is no reason why they should not have a PSA test. And I would say that I would tell them about the overdiagnosis and overtreatment issue, but for a well-informed man, a friend, I wouldn't deny them a PSA test. I would certainly tell them I had a PSA test. And if they want to ask me what it was, I would tell them that as well. So I would lead by example.
Thank you.
Yeah,
I'm not saying I'm 50 yet, but I've had a PSA test.
So, Dr. Prokar, in India, we also follow the smart screening for now almost a decade. And we have also seen that stage migration. Earlier, it used to be like 70-80% metastatic disease. Now it has decreased to around 30 to 35 to 40%, depending upon different tier of cities. And the localized CA prostate have increased to around 20-25. So we also seeing the positive change, and because of smart screening and better diagnostic techniques. So I think that's a good thing for our patients. But my next question is, earlier we were using only PSA and a biopsy to diagnose, CA prostate. And with the advent of multi-parametric MRI and PSMA PET scan, although it's again a controversy whether to use in diagnosis or not, do you think we can reach a stage where we can avoid biopsy for diagnosis?
A highly controversial question from the Meisner paper published this year in the Platinum Journal. The Meisner paper is a German paper, if you're not aware, of 25 patients who had both MRI and PET scanning and were very carefully counseled about the need for a biopsy. But all these men decided that they would have a radical prostatectomy without a biopsy, and the sensitivity and specificity was 100%. So not a single patient in this small subgroup did not have prostate cancer. So the editorial is even more interesting, whereby it's very clear that most people do not agree that this is the way forward. These are very carefully selected patients. And I certainly have seen patients with granulomatous prostatitis, which look exactly like cancer. And if you biopsy it as granulomatous prostatitis, you put them on prolonged antibiotics and it melts away. So I think, given that the side effects of removal of the prostate gland can be significant, I do not think we are there yet. I call this the Angelina Jolie phenomenon. I'll tell you why. Angelina Jolie was very much a proponent of prophylactic breast removal in those with a family history. And 10 years ago, the press wrote an article, I can't remember which paper, where they said that Professor Kirby and I had removed the prostate of a BRCA2 patient without a biopsy. And that was not true, actually. We had biopsied the patient, but that was meant to have been the first patient where the prostate was removed without a biopsy. That is simply not true. And I think we need to be careful and have a diagnostic biopsy, because the side effects could be pretty adverse for the patient.
Yes, Anup. Carry on. Hello.
Anup's dropped out, I think.
I agree with. I think.
I think his internet is a little bit problem. I want to ask question to Dr. Prokar Das sir, that carrying out that message further, that the way the imaging is advancing so much, that you have the MP MRI, then you have a PSMA PET scan, the specificity and sensitivity is almost to 95 percent or maybe 90-95% of time. Do you see that in future, especially with the help of AI and other things, the biopsy will become redundant? What is your, the gut feeling? Maybe 5 years, 10 years down the line, like what we do in RCT, we never do any biopsy, but we straight away go ahead with surgery.
Not immediately, I don't think, simply because you do not want to miss that 1 or 2 patients who do not have a prostate cancer, despite the imaging being as close to 100% as possible. It is still not 100%. And if that patient were to become incontinent, or they have a much younger wife and became impotent, then they would have every chance of suing you in a court of law, and for the right reasons. So I don't think we are there yet, and we will never quite get to 100%. So in very, very selected patients, as in the Meissner paper, that is okay, as long as the patient clearly understands what the effects might be of the final histology showing no cancer of prostate in the gland after removal. So I think that has to be a very, very select group. That is my view on it. People might disagree.
Yeah, Dr. Prokar. In India, we are using like multi-camera patient, and if it is pirate 4 and above, of course we go for biopsy, and if it is less than 3 and less, then of course we counsel the patient accordingly. So I think we are moving in the positive direction, but we are not there yet. So my next question is, over last 2-3 decades, if you compare the definitive treatment for localized CA prostate, radical prostatectomy, radiotherapy, active surveillance, what change do you see in last 3 decades?
So certainly active surveillance was very much there in the early days. And the Brits used to believe in it. The Americans didn't, although it was there, if you remember the early papers. And then active surveillance has made a return. I'm part of the GAP3, which is, as you know, the largest such data set in over 15,000 patients worldwide who are on active surveillance. And I think for the right patient, the grade group 1 and the low volume grade group 2s, i.e. 3+4s, where the volume of 4 is not above 50%, I think active surveillance is a good thing because it preserves the quality of life of the man. Radical prostatectomy certainly has improved, particularly with robotics. It's become more precise, although the trials do not necessarily show that the functional outcomes or the oncological outcomes are better. Radiation has also become better. And if I have a patient saying, well, do you have any comparative data? I give them Freddie Hamby's only comparison of the 3 arms. That is the only sensible trial we have. And if you go to a radiotherapist, them selling radiation, and if you go to a surgeon, then selling surgery, I don't think is the way forward. You have to counsel the patient, and therefore the younger, fitter patient ends up in my hands having a robotic-assisted radical prostatectomy, while the older, less fit patient usually ends up with combined hormones and radiation. So I think all 3 have improved, and I think we are in the correct space for our patients.
So I totally agree with you. But in India, the problem is the compliance and the follow-up of the patients. So actually in India, if I talk about active surveillance, there are very, very few patients who actually, they comply and they come for follow-up. But I think in the future, we'll have more number of patients going for active surveillance. But then the important question.
I agree. In India, that number is 5 to 10%. In fact, I often have patients with Gleason 6, Indian patients who come all the way to London and say, this is my small volume cancer. I can't live with it up here. And we must not ignore the mind of the patient. If they can't live with it up here and they are otherwise fit, then they will have surgery irrespective of their small volume disease. And I think we need to respect that those are the thoughts of the patient. I fully agree.
Exactly. So now in the last 3 decades, when the robot was introduced in 2002 and 4, what change you see like from open prostatectomy to robotic prostatectomy? How many percent? Like in India, I can say we have around close to 100 robotic installations, and we have those centers who have the robot. All of the prostates are being done by robotic, but those who don't have, either they use open or lap, or they refer to robotic. But in nutshell, the robotic approach is becoming more popular as compared to open. And if you talk about your European countries, how many procedures are actually being done by robot and by the other techniques?
Let me start with with UK and my own institution. So at Guy's, we have killed open prostatectomy. There is no open prostatectomy, and we have killed laparoscopic, which happened for a little while between 2003 and 4, but that is also fortunately or unfortunately dead. So when I started in the UK, I was the only person doing this, 1% of all prostatectomies 20 years ago. And now in the UK, it is 94%. Now, as you know, the outcome very much depends not just on the technology, but also on the surgical skill. So if the person closest to the patient is a trusted open or a laparoscopic surgeon, there is no reason why they shouldn't go ahead and have those techniques. I also want to compliment here Mahendra Bhandari and the Vattikuti Institute. We are the King's Vattikuti Institute of Robotic Surgery. I wanted to really compliment the Vattikuti Foundation for being instrumental in bringing in robotics and expanding it within India and training so many generations of new surgeons. So I think robotics is the way to go. Perhaps we didn't get the trials right. We certainly didn't. Perhaps there was an element, a large element of marketing in it. But after 20 years, I'm convinced that if today I was having a radical prostatectomy, I would search out the most experienced person near me, someone who I could look in the eye and trust, and I would have a robotic radical prostatectomy myself. But that's my view on it.
I totally agree with you. I think it's the machine and the man behind the machine. Both are very important. And undoubtedly, the robotic prostatectomy is the answer.
It will be nice to get...
Anup, can I ask one small question to...
Sir, yes, sir.
Prokar, as you know that the modalities have simplified surgical techniques. I want to know, are you aware of any data like when percutaneous became routine or URS or IRS became routine, the number of procedures went in? I assume that overall indicated procedures as well as plus minus indications. Same thing happened with the laser prostatectomies. You have any aware of any data which shows that irrational, so to call, prostatectomies have gone up because it has become much more simpler than open radicals?
I am not aware of any such data because particularly in the UK, Dr. Bhandari, all this, every single patient with a new cancer has to be vetted by a multidisciplinary team meeting. So a rogue surgeon operating on the wrong patients just because the technology has become easier is just not going to work in the United Kingdom system.
Can we get Ganesh Bakshi's opinion on this?
I agree with Dr. Prokar sir's opinion. I mean, that is going to be like that.
So, Dr. Prokar, going forward with this topic, now we have multimodality approach and the tumor board in place, which is almost, I think, standard protocol in all the good institutions. Do you think we are overextending the indication of robotic prostatectomy in locally advanced and oligometastatic CA prostate? What's your experience in these two categories, locally advanced and oligometastatic? Do you think we are overdoing it or they're justified?
I don't think we are overdoing it. So this is a spectrum of disease. The locally advanced, I do a lot of these, particularly in India. Now, today I operated on a really locally advanced tumor. It was certainly more advanced than the MRI and the PSMA PET suggested. And here we have to tell the patient upfront that surgery alone may not cure them, but if it does, well and good, because you then save them from hormones and radiation and the additional side effects. The oligometastases is a different ballgame. And I wanted to briefly mention the state of play internationally, and particularly in the UK. In the UK, majority of oligometastatic patients will have, based on the Stampede trial, systemic therapy and radiation. There's a small trial called the Trombone, which had 51 odd patients, which showed feasibility of surgery in oligometastases in patients with bony disease. Now, that doesn't make it standard of care. There was a wonderful trial being run out of Germany from the Martini Clinic of surgery versus radiation and systemic therapy, but that got killed because Stampede presented its results in between, and that put an end to that trial because patients did not want to be recruited. So I think, in a way, the fact is we don't know the answer to the question. Stampede does not have a surgical arm. I was part of it. We couldn't get funding. And therefore, the standard of care for these patients remains currently systemic therapy and radiation to the prostate gland. Now, that being said, I have operated on oligometastatic patients here. In fact, with Dr. Ghosh, I remember there was a patient who was a Himalayan mountain climber. He is still alive and climbing mountains. We operated on him some 7 years ago. So as long as the patient is well selected, I don't think there's a problem. But in the UK, it would have to be within the confines of the trial.
So I totally agree with you. In India, we also are operating routinely on locally advanced and, of course, selected oligometastatic after taking informed consent and taking the consent of our tumor board. And you're right, it cannot be standard of care right now. Only as an experimental trial you can do in an oligometastatic disease. But going further in this discussion, we have been using robot for last almost 20 years now. Do you think we have reached the apex of these outcomes like pentafecta, trifecta? Are we there yet? Because we still talk about like 3 months continence close to 90%. And then, of course, 12 months, everybody has 95 to 90. So are we there yet, or do you think it's still a lot of scope for improvement? 20 years and still we're talking about 3 months around 90%.
I think certainly scope for improvement. Look, trifecta, as you know, 2 wonderful Italian papers, one of trifecta with the anterior approach and the second of trifecta with the Rexia sparing approach. The trifecta in the anterior approach was 52% at 12 months. You would think with the Rexia sparing, because the early continence is better, that would be improved. It wasn't. It was 42%. And this is from the guy who described the Rexia sparing approach. To the trifecta, if you add complications and negative margins, which is your own Chief Vipul Patel's description with Bernardo Rocco between 2009 and 2011, even there, in the world's highest volume robotic prostatectomists, the pentafecta was 72%. So there's a long way to go. You know, these wonderful images are not 3D reconstructed. They do not fly in to the robotic space. We cannot really see as we are doing things because it's a solid organ. We can't really have surgical data science imposed into the operative field. So I think there's a way to go to improve the trifecta and pentafecta outcomes.
Okay. Going further in this discussion, now in the follow-up period, earlier we used to talk about like early radiation therapy versus salvage radiation therapy. So do you think now we've become wiser in selecting our patients who will go for early versus our last 3 decades? We are selecting our patient now more wisely and judiciously for radiation and ADT in the follow-up period?
Yes, we are. And, you know, this, we are very proud, was answered by the Radical study. I think the whole issue of immediate salvage has been more or less killed by Radical. So it is early salvage rather than immediate radiation. And I think we have gotten it just right. Typically, even in patients with a positive margin, not all of them will recur. We watch the PSA carefully. We certainly avoid giving radiation in the first 6 months or so because of continence issues. And then again, the current flavor, at least with my oncologist, is early salvage because delayed salvage leads to worse outcomes. So the higher, say the PSA gets to 1 or above, the outcomes are worse. So early salvage, but not immediate adjuvant radiation. And I think more and more, except in the very high risk or node positive patients, it is just radiation alone rather than radiation combined with hormones. At least that's what my oncologist, Simon Hughes, who is well known to Amit is doing in London.
Now, going for the last
Anup,
question.
can I ask one question? Anup,
Yes,
can I
yes,
ask
sir.
one question?
Yes, yes, sir. Please go.
Prokar, welcome. Dr. N.P. Gupta here.
Hello, Sarji. How
Hi,
are you?
hi. No, regarding the oligometastasis disease, in India, you know, PSMA PET-CT is very common. And sometimes we have a patient who have got adenocarcinoma prostate 4+3, and he has one spot on the lumbar spine, which suggests that there may be a metastasis. So the question to you is, should we accept PSMA PET-CT for the metastatic disease, or should we do other investigations like MRI of the spine, biopsy of the spine, before we label him as oligometastasis?
If a great question, that PSMA PET is 90% accurate. And if you have an excellent nuclear medicine specialist who looks at the image and says, this is shining up as much as the prostate, I'm fairly certain 90% that this is a oligometastasis, then I would accept it. If there is doubt, then I would do an MRI or even a biopsy of the bone. But in majority of patients, if my nuclear medicine specialist, Tara Barwick, again, a world-renowned expert, calls it a oligomet or a MET, then I will accept it.
Okay,
Dr.
thank you.
Dr. Prokar, going for the last questions in this discussion, in metastatic hormone-sensitive prostate, therapy is coming up in many trials as compared to double therapy. And we have PEACE trial, we have ARCHES, we have Enjamet trial. In India, we started using it recently, the triple therapy for selected patients. And the follow-up is still on. But in your experience, do you think that's the preferred therapy now and it's going to be preferred therapy in the future over doublet therapy?
As you mentioned, those key trials, particularly the Lancet and the New England Journal of Medicine, again, you're looking at hormones, DOSI, and either ABI or darolutamide or Enza. So absolutely, look, I think if you look at the survival curves, there is an advantage to triplet over doublet. As long as you tell the patients that the side effects are also higher, that's okay. So for us, this is in carefully selected patients, particularly darolutamide is becoming very popular indeed, but this is again in carefully selected patients who are well counseled about the increase in side effects with the triplet rather than the doublet.
In India, now the genetic testing is becoming more and more popular in CRPC and metastatic CA prostate. Although
Yes.
it's still available in selected centers and we are getting it done around 20,000 rupees. And we're also
Yes.
using PARP inhibitors more and more. But
Yes.
still, we are not there yet. So what's your experience as the European countries? Do you think the genetic testing is the way forward? It should be done for all the patients?
Well, the queen of genetic testing, as you know, Ross Eales, is at the Royal Marsden and the Institute of Cancer Research. So the short answer is yes. Increasingly, genetic testing with a panel, including BRCA1, BRCA2, ATM, HOXB13, and so on, is being done. Done in two setups, and I presume the audience understand the difference between germline and somatic mutations, but increasingly, one group of patients are the ones who have a history and are young of prostate cancer, and the other is the metastatic setup. And again, PARP inhibitors being studied extensively, particularly olaparib and ABI is being used by our oncologist. Deborah Enting has addressed this audience before. So the niraparib trials are not quite yet mature, so I am less certain about niraparib, but certainly olaparib with ABI is becoming more and more a standard of care. It's not yet fully established in every patient because, as you know, the side effects, particularly anemia and neutropenia, occur in 1 in 4 patients. So again, you have to balance the side effects and the fitness of the patient versus the chance of overall survival, improved overall survival, and radiological absence of disease. So a balance to be found in the right patient.
So in India also, we are using olaparib, those who have positive HRR alterations, and in selected patients, because those who can afford it, and we are following up the patients. And I think this is a positive direction we are moving. We have one more drug in our armamentarium, especially those patients who have failed to the first line, second line therapy. And now my last question is regarding the nerve sparing. You know, there's a plethora of nerve sparing techniques. My mentor, early retrograde, then there's high interior release. Do you think it really matters? They're like different techniques. The outcomes are almost comparable. Do you think that one technique is superior to other, or it doesn't matter? It's the person who's doing the surgery, he matters the most.
I think there are three things which matter the most. First, as you said, is the surgeon. The second is the age of the patient. And the third is their preoperative erectile function score and counseling. I think if you have those three things in place, i.e. it's a younger patient with a nice surgeon with a decent technique, it doesn't matter whether you release it mid-gland like Vipul does, or you go from the back as Mani Menon does. I don't think that matters. But the patient's expectations also need to be managed. Ask me in a few years, because if you look at a recent paper from Caroline Moore at UCL and our own group, despite everything that is written in literature, if you follow patient-reported outcome measures, the erectile function outcomes are pretty abysmal. They are really sobering for a surgeon if you have someone else independent of the surgeon collect patient-reported outcome measures. So one of my current PhD students is going to show the data in the next 18 months, and we will see whether variations in technique, variations in surgeon experience, and so on make a difference. This remains an unanswered question because there is so much variation in literature that I think those are the only three fixed points, i.e. surgeon experience, the age of the patient, and their preoperative erectile function score and counseling.
Totally agree with you, sir. In India, we started using the amniofix or dehydrated immune amnion chorion membrane graft recently because it was not available in India before. Although it's just a preliminary study and we are getting good results. Do you think this really helps, like using the graft after doing a nerve sparing, it really enhances your outcomes, or there is no difference?
So I was using amniofix, and I think there's a whole YouTube video step-by-step from the Vatikuti Foundation, must be now 5 years old, where I describe every step of a robotic prostatectomy, and at the end, I describe the use of amniofix. There is also a similar membrane called Cheetoscan, which is amniofix, but with little holes so that any blood underneath the membrane will come up. And that has been described by Francesco Porpilia's group in Turin, whereas amniofix, as you know, a non-randomized study was shown by Vipul Patel, your own chief, showing better outcomes. Now, amniofix used to add 1,500 pounds to the procedure. And gradually in the UK, it has died because of the additional costs. The NHS was not willing to buy it, and the private insurers were not willing to pay for it. So unfortunately, it's faded from the UK market. But if you have excellent data, and particularly if you are conducting a randomized trial, and I haven't seen the data from Vipul's trial yet, which shows that it is of benefit and the cost can be balanced in an economical fashion for the patient, and has truly changed the way erectile function improves, then certainly go ahead and use it. I am not using it at this time. I was 5 years ago.
You will be happy to know that in India it is very cheap, comes around 2,000 rupees only. And of course, I was a part of the first study published by Dr. Vipul Patel in European urology, and that's what motivated us to use here. And I think we can use it in some patients. The cost is not an issue in India; it's very cheap. And I think we are doing a randomized controlled trial now, and we'll see how the outcomes are there. So I think
how many patients will you randomize?
Yes, sir. We are doing the randomized trial now. So we are doing the randomized control trial now and putting 25 patients in each arm as a pilot study, and we are looking for the output. Yes. So I think, sir, we have finished our conversation. The time is over. So Dr. Ghosh told me, Anup, do not step over the time. So, sir, we are well within the time. Over to you.
No, you can. If there are one or two more questions we can take, because there are some problems with the next speaker joining in.
Okay, thank you, sir. So that gave me some more time, sir.
The
Now,
privilege of another 5 minutes. Yeah, we will get Palak Popat to join in, and then we can begin the next session.
so now, sir, we have seen modifications in technique in robotic prostatectomy, like the recently Hood technique was described by Dr. Ash Tiwari. Dr. Vipul Patel has just published a paper on modified apical dissection. And of course, radius sparing is now not a new concept. So do you think that we are moving in the right direction, preserving the anatomical structure around the urethral complex, so that patient has early continence? Because all these mechanisms, they have early continence. Eventually, the continence at 12 months are almost same. So do you think these are the way forward we should go for these techniques, or our old techniques are good enough?
The short answer is yes. Ash trying to bring in the Hood approach was to try and replicate the radius sparing approach from the front. You can't clearly use it for the large anterior tumors because you would end up getting a positive margin. Likewise, an experienced surgeon like Vipul trying to still continually improve at the apex is the right way to go. I have always believed that the way to achieving early continence is to touch the urethra and its surrounding structures as little as possible. Hein van Poppel, a very experienced open surgeon from Leuven, used to have some of the best continence outcomes. These are published. And the reason he said that he had such good early continence is because in open surgery, he couldn't see the urethra as well as you did robotics. So he just cut the urethra at the point where he could feel it like a guillotine. You know? He wasn't touching the urethra and dissecting it like we do for laparoscopic and robotic surgery. So my message is touch the urethra as little as possible. Do not fiddle with its surrounding structures. And even when you're suturing, I mean, when I do my anastomosis, I do it in a way whereby the pull is on the bladder, not on the urethra. And the whole technique, which Ravi will tell you, is about trying to touch the urethra and disturbing it as little as possible, inspired by Hein van Poppel's message to me saying, do not fiddle with the urethra. So I think we are going in the right way.
Thank you very much. I think we will have...
Sir, you're not audible. You have to unmute.
Hello. Yes.
Yes.
Can you hear me now? Yeah.
Yes, sir.
Thank you for the session, Anup. It was an excellent, enlightening session with Prokar. Thank you, Prokar. The first session went extremely excitingly well, but I think even more excitement awaits. May I now invite Dr. Ganesh Bakshi, who has recently shifted from Tata to Hindujas. That's one part of his excitement. But today, he is going to conduct this session with Prokar Das Gupta in the background. Initially, the speaker will be AI in Diagnosis by Dr. Palak Popat, who I will leave it to Ganesh to introduce, as well as Zishan Hamid, who is going to speak on AI in therapeutics. Ganesh, over to you.
So I think it was a very nice discussion till now. We discussed many aspects, and going on the topic or the select theme for the day, artificial intelligence, out of which many people are excited about it. We have a mentor here with us, a very good mentor, Dr. Professor Prokar Das Gupta. And the first talk is on AI in the diagnosis of prostate cancer. So I invite Dr. Palak Popat, who has been an earlier colleague at Tata Memorial Center. She is an associate professor of radiology at Tata Memorial. So you can share and go on. I think after her presentation, we can have comments from Dr. Prokar, or we'll ask questions to the speaker as well as the mentor, whatever goes well for the discussion.
Sure. Thank you so much, Dr. Ganesh. It's a pleasure always to come here. And I the panel here today. Is my screen seen and am I heard?
Yes.
Okay, sure. Thank you so much. So today we will be talking on AI, artificial imaging or intelligence in prostate cancer. So looking at, okay, why are we discussing artificial intelligence in prostate cancer or artificial imaging in prostate cancer? When we talk of imaging, we have ultrasound and MRI. These are the crux of the imaging modalities that we have when we want to diagnose prostate cancer. When it comes to staging, we then move on to a bone scan and a CT scan. And of course, we have the whole armamentarium of nuclear medicine stepping in with FDG bone scans, fluoride bone scans, as well as PSMA PET CT coming up. So PSMA PET CT of everything that I've said so far possibly has the best value in having a very high accuracy and specificity. But not that it has a role in all levels of imaging and all kinds of cases. So let me go through the essence of imaging. When I'm talking of non-nuclear medicine imaging, we have the ultrasound and the MR. So where is it that we lag and what are the challenges that we face? So for example, over here, this is the transrectal ultrasound, and in here, the gland is seen very well. And then there are some cystic changes seen in the central part of the gland, and the peripheral zone is quite homogeneous, and there isn't a cancer that I can say upfront that this is suspicious. We do put in through a color vascular Doppler, and we see that there is one area which is particularly much more of a higher vascularity than the rest of the areas. So yes, that is a concern. Is that prostatitis? Is that prostatic cancer? We cannot differentiate. So the next thing would be that we do a 12-core biopsy and perhaps a targeted biopsy from this area to get to a diagnosis. However, undersampling is always a concern, and the larger the gland, the more is going to be the extent of undersampling. We do have certain tools such as contrast enhanced ultrasound, where when we give intravenous contrast and the bubbles go into the circulation through the vascularity, and wherever there is an increased vascularity, the contrast is taken up, and then we see, we can see the bubbles burst, they reflect an echo, and what was earlier just not seen, and now when you retrospectively see, perhaps there's a small area which was abnormal and it has taken so much of contrast and echoes thrown out. So this is surely suspicious. So now our accuracy improves, and this is just a reconstructed view, and post later phase where in the B mode we see it as a hypoperfuse area once there is washout of the contrast. So meaning to say, when we talk of imaging, we have fallacies, we have drawbacks, we have challenges. We keep on adding to the imaging, a 2D ultrasound being added by a Doppler, and that being added by a contrast enhanced ultrasound. And that's how medical literature, medical imaging is, that you need to upgrade yourself with the part where you're now going beyond technology and trying to put an AI component to it. I will also show you an MRI. So when we talk of reporting a prostate cancer on an MR, so we have a nice little prostate gland here. Since I am talking to an expert urology audience, I'm sure you all are reading prostate scans in your clinic. And what would happen if we label this as a T2, there is something bright here and there is something dark here, and then there is something dark here again. So this is another cut of the same gland, and then there is some kind of an extra prostatic stranding that I can see. How would you interpret this scan? So I would say that perhaps this may be normal. This is a well-defined area, so this may be suspicious for the peripheral zone. This is also fairly well-defined, and I might call this suspicious. However, there are some classical hypointense bands, which I think may be prostatitis and not really a malignancy. I may not have been provided with the best of diffusion, so then I don't know what this is. So this entire gamut of reading the imaging goes into the waste paper basket. But if you have a good imaging and then you correlate, you want the T1, you want the diffusion. So once you have the diffusion, so again, you have pumped up your morphological T2 imaging with a functional aspect. Looking at the functional aspect, I have restricted diffusion only over here, and it matches with a dark area on the ADC. Now I am wiser with an added functional diffusion component. I know that this is now definitely a PIRADS 4 lesion. Why? Because this could have been 1.5 centimeters, but this is a false value. When I look at ADC, the true area of restricted diffusion is only about 7 to 8 millimeters. So this would be a PIRADS 4, and that's how I would report it. And everything else is probably not disease. Now, the point is the diffusion in my MR machine, the diffusion in another MR machine, the standardization is suboptimal. I may have got some diffusion areas there. Now, if somebody wants to argue, there are few darker areas over here, which were corresponding to certain darker areas over here. So am I missing a cancer or am I not? Or is this, I know this is a malignancy, so that is done with, but you want to move towards personalized therapy. You want to prognosticate. You want to give SBRT. You would want to know whether to irradiate this area or not. I cannot say for sure whether this is going to be prostatitis or not, unless I do a 12-core biopsies, perhaps with a targeted biopsy. I could consider a fusion biopsy, try to get there, and still I can never rule out undersampling. So what I am trying to say is, I will show you a T1 weighted image over here, the post-contrast imaging. This is the area over here was false hemorrhage. This is hemorrhage because of a prostatic biopsy earlier, and that has completely jeopardized my interpretation. And there are these false bands, which are surely prostatitis. And this is a post-contrast, where the post-contrast is not helping me. So in PIRADS, an early enhancement helps, as I am seeing over here. So that tells me, yes, this is a cancer, but what about all the early enhancement coming here and something out here? I cannot be sure, and that is a challenge for me as a radiologist. And it is because of these challenges and my uncertainties at points of time that, okay, I'm sorry, I don't know what's happening here, but I'm sure about this. It's about the uncertain areas where we want an AI and artificial intelligence to step in. So when we are talking about artificial intelligence, what exactly are we saying? We're talking of machine learning and deep learning are the two components. And machine learning essentially encompasses supervised, unsupervised, and reinforcement models. When we talk of supervised models, it means essentially that, let's say I am the operator and I am going to label or annotate every image. So as I said that I showed you the prostate gland and I say that this is a PIRADS 4 and I'm not sure about that other area and maybe that's a PIRADS 3. That's my labeling. So that is called as a supervised learning. And there are certain algorithms which measure the difference between the predicted labels and the known labels, which are my labeled, and they will be called as a ground truth. If I say this is PIRADS 4, when I'm teaching the system, I need to see the histopathology, which would be my ground truth. I confirm that, yes, this was a malignancy. And I say that this is a confirmed PIRADS 4 lesion. And I will look at the core biopsy and I will say that the other lesion is a confirmed non-malignant area, and then that goes as my training data set. This is called as a supervised learning. Vis-a-vis, we have an unsupervised learning where the algorithm optimally separates samples into different classes based on characteristics of the training data alone without the operator having first defined the labels. So this would be where you probably don't have enough manpower for supervised annotation of a large data set. And that's when there is a large volume data set which is being fed into the system undergoing the process of evaluation. And you would have certain specific clustering or other characteristics for stratifying this data. The last type is a reinforcement type, where the computer learns to perform a task through repeated trial and error interactions with a dynamic environment. When you talk of a dynamic environment, today the computer is analyzing by its algorithm, and then there is a next level of information that comes in. And when it has learned something else, it will try to interpret or correlate the new learned feature into the existing one and try to work around it to have a better combined model which works towards a better diagnostics. So that is a dynamic environment of learning, and that is called as reinforcement. So essentially what the steps for an AI would be, which is applicable for imaging and for any studies for prostate cancer also, is you first need to have a clinical data. For us, it would be our PSA levels and the patient characteristics, demographics, the genetic status, histopathology data about the Gleason score, the grade, the genetics, the molecular. Then coming to imaging, where you could have your ultrasound or MRI and all these features. Once you have identified the features that you want to take, they undergo something called as a feature extraction. So you could consider the shape, the intensity seen on an MRI, everything is converted into histograms, the pixel value is taken, and then comes a texture analysis. So once we have this, there is a radiomic modeling process that comes in. So what is a modeling process? It is a feature selection where you summate all your features into an algorithm. At the same time, you would want to remove the redundant findings and the findings which are going to cause an overfitting of your data and not give an appropriate reading. You eliminate the redundant data, you pump in with as much as meaningful data you want to create an algorithm. So that is feature selection. Then comes a modeling methodology. When we move into modeling methodology, so coming to an overall overview of AI, we have the components of machine learning, which is actually having multiple subsets nested within a supervised and an unsupervised type of learning, which I already spoke about. And we have neuronal networks and deep learning. So deep learning is a form of learning where the data acquisition, the training, and the selection, everything is not handcrafted. So it is done with the help of neuronal networks. So when we talk of AI in medical imaging, we have the CNNs or the ANNs, the computed neuronal network. What it does is there are multiple levels, or let's say multiple blankets, one on top of the other. So what does it do? At each level, there is an information which is coming in. There is an input information. There is an algorithm processing. There is some amount of learning that's happening, and it moves to the next blanket or to the next level. Over here, again, there is some amount of learning happening. So the input keeps moving on, and each time the input moves, there is an interconnection that if there is a learning happening at some stage, that learning is reflected back to the earlier steps through which the new data is going to be processed. So this is an interconnected neuronal network, just like our brain. And that goes again for the supervised or the unsupervised part. So it is very important, this method, the modeling methodology of whether it is supervised or unsupervised, it is actually going to give you your output and your results. And it would always be better to have a supervised data and try to, even if you have large volume data, so try to have a supervised data so that your outcome is going to reflect a known gold standard of histopathology. And then comes validation. So when you talk of validation, there are various methods of validation. So validation can be internal or external. So if I have, let's say, 100 scans of prostate MR, and I want to validate my data, I would say 30% for training, 30% for—
A couple of minutes. Can we finish in a couple of minutes?
Yes, sure. And then the next 30% would be for validation. So I can internally validate, but that would be jumbling up of my scans and putting it through a validation process, versus an external validation is where I take data from the biobanks and then that validates my data. So external validation is always better. So these are the steps of AI which I have discussed. The role of AI is essentially to reduce the level of subjectivity that I am not sure component comes down. It shows promise in automating the assessment of characterization and severity or aggressiveness. It does triage patients better, whom to put on surveillance and whom not to. And it also helps to better prognosticate over time. So there is data on PSA levels, improvement by in detecting cancers of the borderline PSA levels. For histopathology also, there is good discrimination between the Gleason score 3 and 4. On MRI also, for us, the goal is clinically significant cancer and not just detection. So we are good at detection based on T2 diffusion and ADC. But when we come to clinically significant cancer, perhaps AI has shown a better prognosis of estimation of disease. So like there are studies where they have looked at ADC, T2 and the aggressiveness, and very good distinction between the grade 7 and the grade 6 tumors. Another study on 164 men on machine learning, and again, very good prognostication between prediction of grade 4, Gleason 4 or less tumors. And again, another study which showed a very good dichromatized data between 3+3 and a greater than 3+3 tumor estimation. PSMA PET CT, yes, it would be covered again in theranostics, but yes, it has a huge role. So I would conclude by saying that AI is welcome. It is here to come and stay. doing more data on supervised data is always going to be a little better to have a better outcome. Thank you so much.
Thank you, Dr. Palak. I would ask a few questions to our mentor here. So, Dr. Prokar sir, how much time you think this AI-based system would evolve and be there on place? Because we have been talking back, the literature goes to maybe 10 years plus maybe to the start, where AI into various fields in various sciences have been started.
I think the monetization of these systems and the small and medium-sized companies which are bringing them in is the factor which is eluding us. There are a number of these which are about to be monetized, some of which I supervise myself. For example, Jiva AI can tell between a cancer and not a cancer from MRIs, and whether it's a clinically significant prostate cancer to the tune of nearly 90% accuracy. So again, it is being put into a number of institutions in their cloud systems and will be ready to be monetized. I will describe later on something called Auto Prostate, published during the pandemic, whereby we can again, by segmenting the zones of the prostate and segmenting the significant cancer, can now generate a report which is in addition to the radiologist report. So it's not trying to replace the radiologist, but it is trying to reduce the variation between radiologists and actually helping triage those patients where you need to really get the clinical input. So I think it's a matter of a few years, and by the time these companies are monetized and in the market, I think they are here to help our radiologists and our patients.
So picking up your last point, monetization of this concept, the radiologists working very hard with the AI. I mean, it looks like in near future, even they might lose jobs. Because
I don't think that is not going to happen.
Would just put machines in place.
That is not going to happen. I have spoken to many radiologists and pathologists, and they have told me that this is good for patients. It's not going to steal their jobs. It's going to reduce the variability amongst radiologists. It is going to triage large data for pathologists so that our experts like Palak can focus on the problems that really need them to focus on. And it will actually augment their reports. It's not going to replace them.
Okay. So any comment, Palak?
No, thank you very much for having me here. And exactly as the last line, we are not afraid of any replacement of radiologists by AI in all the spectrum. There was a time when it was spoken and feared, but over the period of time, looking at the results, it will enhance what we offer. And as new things evolve, we will be required for newer roles. So we'll be there.
Okay, so as Dr. Prokar said, the diagnostics, there is a spectrum and a lot of factors, many factors in the diagnosis, which give us, going to the next topic actually, which gives a spectrum of treatment. Where AI would probably help us is putting in place these patients properly. Today, one pathologist says 3+4, the other says. We have radiologists, like you said, inter-radiologist variation. So probably that use with AI would be there. But Dr. Prokar, do you still feel a person like you or any expert would still take all these factors which today you put in your brain and then you give an output to the patient that I feel it is this, would prevail?
So we can get him to answer these questions in his presentation in 10 minutes.
Sure.
After
so I invite the next speaker, Dr. Zishan Hamid, who is at KMC Manipal in the Department of Urology, Assistant Professor. So Zishan, welcome. I think you go ahead with your topic of therapy.
Thank you, Professor Ganesh Bakshi. I'm BM Zishan Hamid. I'm working as Professor of Urology at Father Moh's Medical College. And also, am I audible?
Yes.
Yeah. I'm also the chairman of the youth organization of USI, and I'm grateful to USI and the Uro-Onco subsection for giving me this opportunity to speak in this forum. So I'll be briefly touching upon the applications of AI in prostate cancer therapy and also on in surgical training. A little bit of literature research will be there, and we'll also speak on our future projects and applications of AI in prostate cancer. So artificial intelligence or AI is gaining a lot of importance, and there are many stakeholders involved in the use of AI in urology. It refers to the computational capability of the machine to mimic and perform human cognitive tasks. It is causing a paradigm shift in terms of providing healthcare and decision-making for the clinicians. Anything which can make a machine become more intelligent is AI. Machine learning is a subset of AI where algorithms are created using data to improve the outcome. More data is used, which makes the machine better and learn more. Deep learning uses multiple layers of neural networks and gives us the more sophisticated outputs. So the key components of AI are machine learning, deep learning, cognitive computing, computer vision, neural networks, and natural language processing network. Object detection, image classification, segmentation, skills assessment, and outcome prediction are examples of tasks that AI can apply to healthcare data. AI has been applied to uro-oncology and robotic surgery, showing strong potential for improved prostate cancer detection and the development of surgical skill assessments and outcome prediction for complex urological procedures. Machine learning algorithms are dynamic and tend to learn more and more as the data are introduced. What it means is we introduce a set of predictors or data and we get a desired outcome using machine learning. The algorithms are optimized in a process known as training to be able to predict the labels by analyzing the explicit features. Once we create a trained data set by using the input layers such as EMR, OR, finance, imaging reports, or functional reports, the algorithm is created. We use a separate data set called as a validation data to make sure it works on a new data set. ML technique, machine learning techniques can be broadly classified according to the type of label and to the type of features. On the basis of the labels, machine learning can be classified into three subsets: supervised, unsupervised, and reinforcement learning. Machine learning can be supervised, where we use a person to annotate the data, or can be unsupervised, where the machine itself makes those differentiation. There are various applications of AI in oncology and medicine. The previous speaker has already touched upon the use of AI in diagnosis. So I'll be, in this presentation, I'll be briefly discussing on certain applications such as precision medicine, AI-assisted surgery, surgical training, and predictive modeling. One of the emerging fields in management of carcinoma prostate is genomics, and the use of AI has gained a lot of traction. The material obtained from the genomic study is so vast that it is nearly impossible to study the sequences such as exome sequencing, whole genome sequencing, or RNA sequencing, which has hundreds and thousands of mutations. By using machine learning, there are various algorithms which can be produced, and AI is essential to relate these mutations to disease state. Hence, genomics is almost dependent on various algorithms developed by AI to treat the patients with CA prostate. The key component of robotic surgery and training is automated performance metric. Automated performance report generation is the form of the analysis of the video, kinematic, and events data from the robotic surgery. Robotic systems generate digital data such as video, robotic kinematic, and events data, which can be segmented into different parts of surgical procedures. AI algorithms process these data to generate performance reports based on clinically relevant endpoints, and these are helpful in assessing the procedure and also the training of the novices. And this in detail will be discussed in the upcoming slides. This is an interesting study which was published recently. By using the Watson software, the authors enrolled 201 patients. The Watson's program provided treatment recommendations using clinical data in three categories: recommended, for consideration, and not recommended. These were compared with the actual treatments received by the patients, and they came up with the conclusion that the treatment recommendations by the Watson program and the actual received treatments from the doctor showed relatively high concordance rate in prostate cancer patients. This was an interesting study published regarding the treatment stratification of patients when metastatic CRPC by machine learning. This machine learning model accurately stratified the patients into docetaxel tolerable and docetaxel intolerable groups, and this has the potential to improve future personalized treatment in metastatic CRPC. Atlas-based machine learning model was used to plan radiation for carcinoma prostate patients. The flowchart here demonstrates the training and novel plan creation pipelines for automated Atlas-based machine learning treatment planning. The colored parallelogram shows the 3 distance metrics, and the results were promising and showed statistically significant dosimetric changes in predicted and mimicked dose. The clinical question of who to treat and who to observe is a major unmet need in prostate cancer. In this study, which was published in Lancet, where the authors used prospective data such as PSA, lesion staging, etc., and they were used to train 2 models to predict the 10-year cancer-specific survival and overall survival with high accuracy. These models can be used online to provide predictions and support informed decision-making in treatment of carcinoma of prostate. The machine learning algorithms can also aid in predictive modeling. Using machine learning software, the authors came up with the survival quilt cancer model using the SEER dataset of almost 171,000 odd patients and compared with the other existing models such as Memorial Sloan Kettering Cancer Center, AUA, NCCN, EAU tools, and almost 10 such tools, and they could easily compare the features to see which model is the best. This novel tool can be helpful in predicting cancer-specific survival in carcinoma prostate patients. This is an interesting project where it is known as ASCAPE, which is artificial intelligence supporting cancer patients across Europe. And this project stands for AI supporting these patients with carcinoma prostate and carcinoma breast. And it aims to provide personalized and AI-based predictions for quality of life issues in prostate cancer, as well as to suggest potential interventions to the physicians. It is mainly based upon patients' data gathered through medical records, questionnaires, and also by using certain apps. And this can predict the quality of life in patients with carcinoma prostate and also carcinoma breast. The simulator-based training in urology is gaining a lot of importance of late. And as I discussed earlier, the various APMs can be used, and these can be objectively recorded and can be used to train the novices and also the trainees, and it will help in improving the overall surgical outcome and also training for the residents. And also certain AR/VR projects are in pipeline, which also are embedded with AI, so that there is a better visualization of the anatomy and also procedures, and it can be used for training the trainees and also for educating the patients before surgery regarding certain procedures. The training in urology at present, we have a mentor or chief observe the surgery performed by a trainee or a novice and give feedback. This conventional training method is subjective and with a lot of bias and errors. In order to overcome this, this virtual operative assessment tool was developed by neurosurgeons, which I think in future will be used in various other subspecialties. The virtual objective assessment is a program used to measure the objective training. It gives a real-time auditory feedback and percentage of skills achieved. If the trainee has not achieved competency in all safety metrics, the trainee cannot proceed further and must redo the scenario. If the trainee has achieved competency in all safety metrics, the trainee can move on to the next step. It's a step-by-step, training program where once they achieve the certain metrics, they can move into the next step, and it gives a real-time auditory feedback so that the trainee can improvise while they're doing the procedure. Here you can see the screen also provides individualized feedback on 2 instrument motion metrics accompanied by statements on their performance. In order to measure the objective assessment of the various surgical steps and proficiency, there's a black box tool which can assess the surgical videos and also the kinematic data as how many times the surgeon has moved, how fast is the skill, pressure applied, and various events provide automated performance metrics. For example, if you want to record and plot a graph to show how many times the instrument has been moved between an expert and a novice, you can see that the expert is more focused and narrower in the narrower space. But when it comes to the novice, it's more haphazard and it's all over the space. Before we didn't have any program to measure this, but now there are certain groups which are working on this so that we'll have a measurement of various key steps in the procedure by using the APMs. This was one of interesting study which was published recently in European Urology, where they used APMs, almost 41 of them, using clinico-pathological and surgical scale performance to assess the overall outcome of radical prostatectomy. And for surprisingly, one of the APM, which was needle positioning, was found to be outperforming the other APMs. And if you look at it, it can be quite key in all our procedures that needle positioning should be one of the key step which has to be done properly so that the procedure goes smooth. So there are certain papers which I would want to emphasize on. This was one of the work done by us. We had done
Zishan, can we finish in another minute or two?
Okay, I'll just quickly run through them. Yeah, this is something which I wanted to stress upon. Right now, the legal and ethical considerations for use of AI in healthcare is still in its infancy. There is no agency which is set up in India right now to be blamed for anything which goes wrong while using AI in our clinical practice. What we should always think about is to have a proper data to be fed so that there's no garbage in and garbage out, and we have a accurate data which is fed so that in future, if there is any law which comes up, we will be held responsible, not the program. And these are certain projects which we are running. We are doing a lot of projects in endourology, and this is an interesting app which we developed to visualize the interior of the kidney. But similar things which we are planning for uro-oncology, where we can visualize using the DICOM images, we can visualize the pelvis, we can see the tumor, the extension of the tumor. And this app is already in Google Play. This is our other company which we are working with certain AR/VR experts, where we had a pilot study where we tried to use AR/VR for puncture of PCNL. Similar things we are working for CA prostate in future. So at the end of it, it is not one data set what we are interested on. AI has the capability of combining various data sets such as molecular and thereby molecular radiology, clinical and pathology, and thereby give more personalized risk assessment tools or treatment suggestions tools to the clinician in order to provide individualized treatment and cater to precision medicine by using these multiple sophisticated data sets. Thank you all for your patient listening.
Thank you, Jishan. I think before the oration, we'll move on to a small presentation from Dr. Prokar Das Gupta, who is the mentor here. And as you all know, our multifaceted star for the day. He is well known to everybody. So Dr. Jishan, if you can stop sharing, we can invite Dr. Prokar for the next presentation.
Right. Zishan, Palak, that was absolutely fantastic. So I'll give a 10-minute overview of where we are with this very exciting story and how I think AI will transform the landscape of urology. Look, AI has to be for everyone. I'm going to keep it really simple here. One of the most intelligent devices that we have is in our pockets. It's our mobile phones. Imagine you're walking in an alien nation where you come across this sign, you have no idea what it is. You take out your mobile, you point it at it, and it tells you that there's a danger cliff ahead. So this is an example of AI just saving your life. So this can't really be for a few. It has to be really for everyone. Part of AI is machine learning, as has been already described, and I want you to think of it very simply, using data to answer questions. That is all it is, using data to answer questions. There are 7 simple steps of machine learning. The first is, if you have to use data, you have to gather the data, then you have to clean it up, as Zishan said, garbage in, garbage out, so you need clean data. Then choosing the right model. As for example, imagine you choose a model that can tell the difference between beer and wine by the color of the bottle. Then say you have 1,000 bottles, you use 80% of those bottles or 80% of the data for training, and then 20% roughly for evaluation. And you will see this being repeated in most of the papers that have been presented thus far. And then you need to tune the parameters because the algo will not get everything right the first time, and then you get the output prediction. So I want you to think of it very simply as 7 steps of machine learning. Now, this is what is called the convoluted neural net and deep learning. So say you want to have the input of the number 9 and the output you want also as the number 9. Now, you break it into pixels, and then you pass it like the human brain through axons, through this neural net. And all deep learning means is if you have more than 2 hidden layers in between the input and the output, then it's called deep learning. And the clever thing this does, unlike the human brain, is in the human brain, the signal goes from this direction to that and to that until it gets it right. Here, it'll go here, then it'll go there, and suddenly it'll move there, realizing that perhaps it is not right. The way this works is it then has something which the brain can't do, which is called reverse propagation. So it'll send the signal back till 9 is read as 9. So this is the clever thing about deep learning. Now, if you want to read more about the subject, Palak and Zishan have already presented some of the best papers. This is an overview with Andrew Hung from USC Tech and my own group in the BJUI. We've deliberately kept it very simple, over 100 articles, about 60% looking at diagnosis, 30% looking at outcome prediction, roughly 10% looking at treatment plans, for example, outcomes of PCNL and how to plan a PCNL, and then about 10% looking at skills evaluation. So here is, to me, one of the best papers in AI just published. This is called the Panda Challenge and was published in Nature Medicine. I was asked to write the editorial to this, and this is my editorial if you're so interested. Now, the Panda Challenge involved 10,000 plus biopsies for training, over 2,000 for validation, over 1,000 teams with nearly 1,300 participants from all over the world. And the algorithms achieved pathologist level performance across Europe and US, and the European counterparts did not know those in the US and vice versa. So this is externally validated, very, very significant. And the way it did this was using a deep learning system that I've just described, and the system outperformed 10 of 15 pathologists. So remember, Panda is more than just a beer. This is the Panda Challenge, and it's well worth a read. The other example, which has already been shown, is again from Andrew Hung. He has 2 NIH grants, and the main takeaway is this surgical video from the Da Vinci being attached to the black box. This has now gathered data for the Royal College of Surgeons mastery study, which I'm part of, in 500 different operations, not just prostatectomy, but also gynecology and ENT, and looking at instrument kinematics and systems events. And the most interesting thing from this is direct patient benefit. There's a suture at 5 o'clock, a deep suture, which seems to lead to the best continence. Now, my eyes couldn't see it, but that is what one of the outcomes is from Andrew Hung's work. Now, the other thing that we have been doing particularly during COVID, is remote surgery. So the human brain can deal with 10 milliseconds of delay. Obviously, that increases if you go and try to operate between London and Paris. And if it is London and LA, then, well, it is almost impossible to do that. So we have used 5G and now 6G softwareized networks and AI to shrink this delay so that the brain thinks it's only 10 milliseconds. So the way we have done it is used a headset, HoloLens 2. We have a neurodigital glove developed with a company in Spain and my own group. This can feel inside the patient without making an incision. We have 3D printed little robotic tools, which has been designed again by one of my readers. And then we have real-time slicing used doing SDN switch. And this is where 5G comes in. I performed the first such procedure on Facebook Live. And then the next year, our contemporaries in China did a hepatobiliary case with a different group. Finally, a few words about imaging. This is Jiva AI from the National UK Entrepreneurship Program, which can tell the difference between cancer and no cancer and the different grades of significant cancer with nearly 90% accuracy. This, as I said, is already in the cloud in a number of different institutions. This is autoprostate. I mentioned this to you, a recent paper from Sebastian Orselin, who heads up our surgical and interventional engineering lab at St. Thomas's. I would urge you to come and visit us. This is the largest medtech hub currently in Europe. So we can segment the zones automatically. We can segment the clinically significant cancers and then add patient and clinical data to generate an auto prostate report in addition to the radiologist report. Again, this is going to be monetized pretty soon. And then you can take those 2D images and use something called Mona AI label. This is in combination with NVIDIA and Cambridge One, which is the fastest current algo that is available. And you can volumize these 2D images into 3D. Look, this is a complex structure like the heart. You can now do this in an autonomous fashion and get a 3D print. So what we have done is use 3D printing in prostate cancer. This is a 3D printed prostate. That's an anterior tumor, as you can see, literally a millimeter from the sphincter. The nerve bundles are way out. And this is actually a P3 cancer. This is the actual prostate removed. And this can reduce margins from 35 to 10% in P3 disease. Now, what about AI in robotics? This is the CMR Versius robot. And as you can see, the surgeon is not seated at a console, but is at an open console with 3D glasses. These are modular instruments. We have just published the ideal stage 1, 2A first in man in the BJUI in 10 patients. So this is really a very stringent first report, the first such prostatectomies in the world. But the most interesting part of this is we have a combined PhD project with a scientist and a clinician looking at surgical data science and the surgical field, using the entire field to see what the voice interactions are between the surgeon and the team sitting near her, and also the instrument motions to see if we can improve the performance of the next generation of surgeons. Finally, I think a word about automation and AI. This is the STAR robot, as you know, which can suture bowel better than a human being in a pig intestine model. This is already published in Science Translational Medicine. So during the pandemic, we got a major grant called Trustworthy Autonomous Systems. This is a review from my own group in Nature, and the press got hold of this. This is a very large grant because this is 3 organizations together, Southampton, King's, and Nottingham. And they said, well, you have nearly 30 million patients waiting. Why can't you program these machines so that there are machines in 7 different rooms doing what you do in 1 room? And I think this is fallacy. Just because today a machine can suture better than a human being doesn't mean that every patient's anatomy is the same. So I think we are way away from having complete automation. This is science fiction, and to think that a robot will reduce the workload, and reduce the COVID pandemic backlog while I sit and have coffee is just pure science fiction. So that's all I had to say. I hope I've kept it simple enough, and I'll be happy to take any questions. Wonderful talks. Thank you. Fantastic.
Yeah, thank you so much. I think that was a good deal of learning for us in the AI, ML, deep learning thing. And you opened up pretty good windows to the people attending this seminar. I mean, we got a glimpse, and I can ask the audience if there is any one question from anybody. We are slightly going late.
We'll take that after.
So I invite, I think,
senior-most speaker today, who has got the last word this evening, Professor Mahendra Bhandari. Over to you, sir.
Welcome, sir.
Hello.
Society of
Hello.
Hello.
Can you hear me?
Yes, sir, we can hear you.
Do you see my screen?
Yes.
Yeah,
Okay.
you have to make full screen, sir. Yes, perfect.
Good evening, everybody. Dr. Subnis, the president of the Urology Society of India, my dear friend Prokar, ladies and gentlemen. It's a singular honor to have been invited to talk before this august audience. I would try to keep my impressions of urology in India 50 years ago and now, and would be very careful in every word I utter. So, first thing which would disturb some people is why I don't want to use the word artificial intelligence, because there could be different views, but my view is that there is nothing artificial I find in it. Maybe it is gaming, maybe it is business intelligence, maybe it is healthcare. It is humans are behind the machines, computers are means. It's created by humans to be used by humans. So there is nothing competitive about it. It is complementary. This is my disclosure. We have a grant from NSF. This is disturbing. I don't know why this message is coming. Do you see this message?
Yes, as you talk, your talk is coming in the text format.
Why it should come, I don't know. So
I thought it's artificial intelligence. So go ahead, sir, no problem.
okay, so I begin by trying to say that Steve Jobs was just 50 years before he said for the computers that they are the bicycles of the mind. I went to his original article, and why did he say so? He had pulled out the data of all the species and looked at their characters to walk and run. Humans were the slowest in running. And that's why he thought that human mind needs an acceleration. And that is why I would call it an augmented intelligence or accelerated intelligence. Now, let us see how we guys solve the problem in business as usual. Had there been no AI, no computer, no cloud computing, no AWS, we would have a complex problem and we'll create a critical mass of multiple people to solve a problem, but which we call the collective wisdom. To prove the point, you'll have to hear a story. This, I'm sure you've heard about the American boat race, which is the oldest international sport. And New Zealand is the defending champions for that thing, a small country of 5 million people. And this race is billions of dollars is being spent in winning this race, which had narrowed down to two variables. What is the design of the boat? And number two, the sailors, the skills of the sailors. And New Zealand has inherent skills in sailing, so it was considered to be it. As the competition got really heated in 2017, New Zealand team realized that they wouldn't be able to win the usual way, and they said that whichever boat would have best simulation would win. And they hired McKinsey as their consultants. And McKinsey put a bot, which you see here. And this bot was put in, and the sailors were on and off brought to the bot, and the bot was left to learn on itself. It was fed with tons of data, which they had, historical and prospective, on sailors, on surroundings, sea conditions, weather, and the boat designs. And you know that it surprised everybody that in 1,000 hours of training, the boat excelled the best of the human sailors. And what they did was, because bot did not need any kind of lunch hours or anything, continuously it could work. It did not have any discussion times, and it was just collecting data. And then they found that, and it could be, hello? It could be simulated to multiple variables at a time, to speed, to all the variables it could do. Now, this example clearly shows that if you translate it in surgical terms, according to me, current master-slave system of the robot is the biggest bottleneck concept, which I personally believe. Everything, because in the interest of the patient, I understand fully, it has to go through the robot. But the bottleneck is the surgeons. If you are looking for decision support systems and next generation of robots, the only way is, like it has happened in AlphaGo, it has happened in New Zealand, winning the race, is to leave robots to learn, and then learn from the robot about the hidden insights, counterintuitive movements, to really move the surgery to the next level. Already Palak and Jishan and Prokar iced the whole thing. They have done a wonderful job. Since I was asked to talk on uro-oncology, I would bring this latest slide from Lizzie Hine. And if you see that if you try to see AI developments, urology is very low in terms of overall clinical uses of AI, but the diagnosis of prostate is the biggest bubble, then surgery of the kidney, and recurrence and progression. This is the current statistics. Let us go back to the history, what AI has done. At least Dr. Gupta and some of the audience, including Dr. Bhatyal, will and many I have not seen, would believe that our practice was only IVP and KUB when we were trained. And thereafter, having a C-arm image intensifier and C-kidney into two plane was a big, big advancement when thing came. Now, 3D printing soft models are a standard of care, which gives you better feel of the personal anatomy, and all of you and many of you are using. As I see the imaging, as Palak has really made a very strong point, is acting as a bridge between the diagnosis and treatment. And the future machines would not discriminate, like semi-autonomous vascular robot doesn't do a diagnosis separately, and cardiology is in forefront of all this. And similarly, a lot of augmented reality systems would differentiate between this. To give you a glimpse in the future, this is optorobotics from ETH, wherein micro robots are being used for imaging of the vessels. And this is something which is very close to the whole thing. Though the previous speakers have mentioned that what is the similarity between the human brain processing an image and a computer processing an image, you can see that eye can only see partial truth, not the whole truth. Its only scope is 180 degrees. Computer gives you a three-dimensional view of the whole thing with the image treatment possibilities. So basic principle remains the same, but computing augments the quality of image. Computer imaging, we did some work on live donor nephrectomies, creating models for renal artery, renal vein, and I must acknowledge that my entire work with a very, very strong team of ready minds. They are partners and we have collaborators everywhere, which I'll acknowledge. So we worked on computer vision model in order to create this supervised model and label these images and raw data. And then we automated the process of image selection, automated the process of differentiating between the annotator's errors and a consensus. And then finally, it was already said, the data cleaning, processing, augmenting, and optimizing the model. One point I'll tell you, which is very important, that most of the models are reported on intersection over union, or what you call the data models on ROCs. But what matters is validating these models. Until these models go to clinic, they are worth it. And these painful annotations are a relearning for us. Surgeons know only two things in their surgical anatomy. I can afford to point fingers because it is pointing at me. We do not know the anatomy because computers are no nonsense. If there are two branches of the renal artery, you have to know there are two branches of the renal artery. If it is ascending pharyngeal branch or it is, so I think there is a lot of learning. And then we made this model performed exceedingly well. And you see the 3D of the model, which identifies the renal artery, renal vein, and spleen in the first go because this was a pilot. And then we could do a 3D reconstruction. Now, what do you do with this work? And then we went to the next level of thing that, so then we had to optimize the model, and we found that a lot of artifacts are there because if you are going to register the model, then we competed and we won this competition at MICAI. You see, this is the surface of the kidney. Now, how many of you see the surface of the kidney so uneven? But computers would. And that's why the subject is coming to a halt in terms of there's a bottleneck in registration. There are lots of work going on. Lots of approaches have been used on registration and tracking of these models, but nothing which I can see which could help a common urologist in the market. So the computer vision work is being used for this. Of late, we have been very interested in creating an effective user interface in terms of getting off from the head-mounted displays to video displays, but obviously the route to those have to be through head-mounted displays. And just to tell you, these are the alternative realities you may call with different combinations and permutations. At one end is the real world reality, and at the other word is the virtual reality, and rest of it is people have used that, there are n number of terms to do that, including diminutive reality, wherein you subtract what you don't need, take away the noise. These augmented reality models really bring everything to the thing. And as Jishan mentioned, it has been used a lot in terms of training people and knowing the anatomy well. And it's almost literally a spare part surgery. But let me tell you that everything depends upon the quality of CTs you do Everything depends upon accurate labeling of these and building these models. Now, what is in the future? This is not our video, but this is Siemens, and that is what is there. Is a virtual room, operating room, and moment these head-mounted displays are turned into a scanner, you can do a virtual pan body scopy of the patient on the operating table and know for yourself, and that brings predictability to surgeon, and we are there. You can walk in. These models cardiologists are already doing in structural heart diseases and pediatric heart diseases and doing that. And we got excited with this work, and we did a little work on this area. And I'll give a little background of this patient. This was my own patient. I had operated in 1992 for right-sided pyeloplasty, and the patient did well, and we had forgotten till she contacted me back after that with a recent condition that she has had a ovarian cancer, and she wanted me to help her with the treatment plan. So this patient was, so we did a whole body walkthrough with a virtual reality model. Painfully, the whole thing was modeled, labeled in by one of our collaborators in Brazil. You see that this is the right kidney in question with the what you call scar in the kidney because of that. And I cannot show you what I see on my HoloLens Oculus, but you see that this is the tumor. This was all done ex post facto and validated by surgical notes. This is the bladder. See this. There was another question because the ureter was dilated and they were wanting to know whether it is because of the recurrence of the obstruction in the PUJ or it was somewhere. And you see this blue tumor compressing the ureter. So literally you can go through tissue planes and you can see whether this is involving a particular organ or there would be a plane of cleavage for the surgeon. This was low-grade serous carcinoma, fortunately, with multiple bumps in the abdomen of the patient, and the black is the tumor you see. I'll jump up. This is the kidney. You can see the surgical dent, what you see down. See, again, this is the tumor you can see here. This is the right side ovarian mass, which was huge mass here. Now I'll jump over to the post-operative of this patient. And fortunately, the surgeon did a great job because this tumor was non-responsive to carboplatin-based chemotherapy. And after 6 weeks, this was declared as no response. In fact, tumor grew and the surgeon decided to go in and give a R0 stage. It is 16 months since the patient is doing well. You can see that every place the tumor was, our model was able to do. This is an ileostomy and this is post-surgery, a totally clean patient. Now, I brought this example not to show that it's how great the surgery was done by the surgeon, but to show you where all artificial intelligence could have helped or augmented intelligence could have helped. And that is that number one point goes to that there was no need to give trial and error carboplatin-based chemotherapy, which is a standard of protocol for treating ovarian cancer. We could have personalized with genomic profile of the patient. This patient had a genomic profile, but it was done ex post facto. Similarly, surgeon could have been helped more than CT reconstruction by 3D walkthroughs to really make an assessment of the tumor, what he is going to go through. Now, let me come to another area of predictive modeling. And here I must give a lot of credit to my friend Prokar, because we were very excited when we started this work, because there were two papers which I came across from Rajkumar Alvin from Google, wherein he had used hospital data from 4 centers and used FIRE to merge that data and build the models, showed a good outcomes. And second was the king of predictive model, Angie Nagel from Stanford, who has done model on the heart failure. And at that time, I published a conceptual paper, which only appetite like British Journal of Urology under Prokar's thing could have accepted, because Prokar, we are already missing your absence. We are ahead of times and no urology journal is willing to touch. The last paper was reviewed by a journal and 5 reviewers wrote that we don't understand what is all this. And so we don't understand, reviewer would not, I mean, say readership would not understand. And here, this algorithm still remains the same for predicting models, which is same as data cleaning, data dressing, and then building the models and optimizing the models, revalidating the models with a feedback loop and making the model robust. But when we actually went into the ground, it's just to tell you a failure story. We wanted to have a data which would fit into big data, and we could lay hands on Mimic3 data, which was an ICU data, and it was a huge database with 3.5 million parameters. If you take the chart events, but if you take the whole events, it was 15 million parameters, and the model performed exceedingly well. We published this paper. Where do you go from here? Because the objective was not to publish by showing that the model performs well. So then we run that VCQI database. So we thought it would be very handy. And these are all learnings on the job. I'm trying to say that if you get excited, once you go in, then you will realize that you cannot compare healthcare data or your what you get, hospital information data, electronic record data with 1.5 or 2 million data from the Tesla car. They generate their own data and they control the whole data centers, and each car is feeding data every moment. So we realized that we have 28 centers participating. So we built a model on 30 days morbidity in partial nephrectomy and what you call intraoperative complications. And the model performed well. And we were excited. Why we did so was that we thought that I have a captive audience. I'll be able to take this model to the clinic. We even designed a cloud thing. That moment the feature selection of 15 features would come, it would be picked up, and there would be a feedback loop for me to make the model robust. It did not work out because we selected a wrong complication rate was only 1%, and you needed a very huge data to really come with a model which would be able to predict complications. Not only that, to our surprise, how data characteristics changes affect the model. When I did that, my thinking was more the data, more the model should improve. And we had 300 cases. By the time we published this paper, we added those 300 cases and model performance dropped from 70 to 40%. And we were putting our heads together and just to find that one of the centers, which was the largest center contributing data, had withdrawn for contribution. So now where do you go from here? So I think the point I want to make is before you venture into this, you need to, then we did our group published with Henry Ford Transplant Center on UNOS data, which is one of the best data sets on transplant. And they published this, and this model also performed well. But the point which I want to tell you, that until you can take all these models, whether they are computer vision models or database models, to turn them into clinical decision support systems, or you can use them for clinical care. They would continue to be work in progress, exercise and academic exercises, which we have not been able to be successful. Now, where is the stage? I would say that there are few FDA approvals, and Page Prostate is one of them. And this is something which is pretty 2021. It has got approval. 16 pathologists examined 527 things and biopsies, and it improved the performance of the model. So now, as was discussed previously, what do you expect from the artificial intelligence or augmented intelligence-based models is, number one, it would make surgeon more predictable. He would not really blame the disease all the time, but he would be able to predict it. Second, it was very rightly told by previous speakers that it would take away the intra-operator variability, particularly in pathology or interpretation. So first education is that whenever we ask anybody, he said, we have a very good electronic record system that is not good enough for data. The big data definition is totally different than what we have been handling on relational databases. It has to be volume, and volume is not the only thing. There is a law of diminishing returns. Beyond a point, if you keep on feeding the data, model will reverse perform. So it's optimum volume, the variety of database. In other words, the variability should be such that it should cover up all the probabilities and velocity of the data. That's why ICU data is most conducive, wherein you have periodic blood pressure, periodic chemicals, and blood gases done for that purpose. Variability is consistency over time. And most important thing is, as has been repeated, that veracity of the data. Until the data is trustworthy, don't expect models to perform well. And the value. Now, this point I want to emphasize that one mindset has to be changed, that in our usual publications, retrospective or high evidence publications, we base it on the already historical or archival variables. And we play around that and produce a high level of evidence with a high level of study or a clinical trial. But what I would like to emphasize here, the point is that here you have to begin with a clean slate. You have to put as much data or a quality data as you can without thinking, and let model tell you the hidden insights. Thereafter, if it gives 100 variables, you cannot deploy that model in the clinic, and then you do the feature prioritization, which is being done ably by our team in order to narrow down to the variables which would be feasible to be practiced in the clinic. Another point I would like to say, we are documenting the least amount of data. I haven't seen any proactive effort to go beyond blood loss and console times and all. In comparison to other areas, until we proactively think of physiological or biochemical data in terms of by planting, at least for research purposes, planting sensors and trying to take advantage of our anesthesiologists doing physiological parameters, we will not be anywhere close. I would like to just tell you the most exciting thing, which is nowhere close we are, but I hope that one day within our lifetime, we'll be able to see human digital twins. Twins are not unknown for the industry. I can guarantee your car has a twin with the manufacturer who is able to sense what troubles you are likely to have and rectify them. currently you can implement digital twin technology for mountain bikes is simplest thing, where you can correct the parameters and build a personalized bike according to the circumstances, riding tactics of the bike and terrain he's working on. Now we are talking of a human digital twin, and wherein you create a virtual replica of the human being and see the progression of disease before it actuals. The advantage is you can create several twins at a time and model them through different drugs. It's a digital component. It's just a human, not a face. It's all data. And you can model and try different drugs like the patient I talked to you about. You can try different drugs. You can try different modalities. You can literally see how you see the growth of the disease. It's a very exciting concept. Cancer patient digital life is more promising for the simple reason that cancers with increased survival and your efforts and the modalities coming on has a long way to go. And it's not important that how long a patient has lived. More important is what is in his store in the next few weeks or months. Now, here is an example what you expect from digital twin. A metastasis comes here, but the twin would have picked it up at a stage when no radiology techniques or machines would have picked up here. And that's what we want, because all of us know that at this stage, it's much easier to deal with it when it is visibly seen. So I think I am almost coming to end of a talk. Artificial intelligence is a friend or a foe. It is for you to decide, and I agree with Palak's statement that it's going to stay. And let me answer one more question raised, that would it put it out of job? Let me tell you, yes, it will put people out of job, like it happened to the Kodak company, one of the darling companies all of us have used for the years, because Kodak was disrupted by a small company of 13 people in Instagram overnight because they ignored signals for 3 quarters. Why did they so? But because Instagram created and the digital technology created much more jobs. So radiologists or anybody would be threatened if they don't change their job skills or upgrade their skills. So what will happen? Yes, they don't need usual radiology, but they would need radiologists who would have additional qualifications, or so the scope of radiology would change, and hence people who would like to be static are likely to lose the jobs. So I think, thank you very much once again for this opportunity. And though you call it oration, but I'll be very happy to take any questions.
Thank you very much, Professor Bhandari. I think this has been a wonderful Star Trek presentation for many of us. We've learned a lot. I would invite Dr. Keshav Murthy for the closing remarks or any questions that he can actually engineer to this great faculty that we have got today.
No, I don't have any questions. It was an exciting session and stimulating one. I think the younger crowd would be drawn towards this. You have to, as Bhandari told, if you are static, then you don't progress. And we have to have surgeons who will think of this. Apart from learning medicine, we'll have to learn technology also along with that to be progressing. Wonderful. I would, on behalf of USI, thank Dr. Bhandari, Professor Prokar Das Gupta, Dr. Palak Popat, and Dr. Jishan for the wonderful talks we had today on artificial intelligence. And also thank Dr. Amit Ghosh, Ganesh Bakshi, Ravi Mohan Mauduru, and Dr. Santosh for this enlightening session from the Uro-Oncology subsection. Thank you all.
Thank you.
Thank you. Thank you. Good night. Good night.
Thank you very much. Thank you so much.
It was a mesmerizing talk, sir. Thank you.
Bye-bye.
Bye.